Welcome to Samsung Medical Center again. I am the Hyeon-Cheol Gwon. This is Hyeon-Cheol, my second operator, working for Samsung Medical Center, and Taekyu Park, the third operator for TAVI procedure. So, Dr. Che, will you introduce the first case?
Yes, I will present our case. Next slide.
Slide on the screen, please. Okay.
Yeah, this is 78 male patient. He presented with DOE, near class 2.
베어메탈 스텐트가 길이가
And
얼마나
test
있어요?
history, he has no hypertension, diabetes, and hyperlipidemia. In 2005, he underwent valve repair surgery, so mitral valve repair with mitral annuloplasty and tricuspid annuloplasty. And 2 months ago, he underwent acute cerebral infarction treated with thrombolysis. Logistic score is 16%. Next. This is a thoracic echocardiography finding. A mean pressure gradient is 79, and maximal velocity is 6 meter per sec. The aortic valve area is 0.6, and AR is mild. Next. Annulus by thoracic echocardiography is about 24 millimeter. Next. This is a CT angiography, and sinus pulsar is good enough, and the sinus tubular junction is enough to deploy this device. Next. So annulus perimeter is 81, and annulus area is 506 millimeter square. Next. You can see the CT imaging, just the annular portion, we have a lot of calcification. That's the the projection view is AP caudal. Next. The length of left main and RCA is good enough to implant device. Next. Peripheral angiography showed the heavy calcification in the both common femoral artery. However, another is good enough to deliver the device catheter. Next. Yes. Femoral artery angiography is good. Next. So this is a brain MRI. You can see the multiple infarction area is both lobe. Next. So this is angiography, left coronary artery angiography. You can see the tight stenosis of left main os, and right coronary is no significant stenosis.
Left main MLA 정도.
So according to the annulus size, the perimeter, Scipion 3 valve is acceptable. The size is 26 millimeter is acceptable to the deployment. Next. So our plan is the transfemoral approach and PCI for left main os lesion, and estimated size is S3 Sapien valve 26 millimeter. Okay.
The issues here are definitely a left main disease, osteal disease. So I'd like to show the angiogram and IVUS today first. Angiogram on the screen, please. Yeah, it's epicaudal view. You can see stenosis left main, calcified lesion, and the vessel size is huge. Okay, another view. No. Spider view again. So actually,
IVUS.
the IVUS, please. IVUS 그거 지우고 그냥 줘요. From the distal.
Okay. Distal부터. Okay.
Okay. This is a LED. The vessel size is 5 already. This looks left main to unfortunately about 6. Vessel size 6. Calcium nodule in 7 o'clock. Around here, you can see about 60%.
Yeah.
Stenosis, heavily calcified lesion. So issue here is that can we do the procedure, TAVI procedure, without treat this lesion, or we should have PCI? We should have done the PCI before TAVI, or we can do the concomitant PCI. So another issue is that this patient had a stroke 2 months ago. So when do you think is the optimal the time to do the TAVI after a stroke? So we suggest 2 issues, and I'd like to get an advice from the panel.
Dr. Gwon, what is the current medication to the patient?
Yeah, aspirin, clopidogrel, the routine medication. Nothing special.
If the patient physical status is quite stable, the concomitant left main
Quite
stenting
stable.
and the TAVI procedure is available in this patient. However, before that, we have to evaluate the status of the stroke. What I mean is that did you evaluate the source of the stroke for this patient, particularly in the carotid artery status?
Yeah, MRI show. Yeah, MRI showed the disease, the stenosis, and occluded the artery in the MCA. So this is not embolization, just the infarct and by the coronary occlusion.
Is there any disability of the motion or sensory in this patient? Or completely?
Most likely he has some weakness in both hands, but mostly he's quite good condition actually.
Anyhow, during the TAVI procedure, there's some emboli should be inevitable. So in these cases, if there is some significant stenosis in the carotid artery, it makes a very significant and disabled status for in this patient, particularly in the recovered functional status.
Yeah. Right. You know. So, but I don't think carotid disease is a major risk factor of embolization during the TAVI procedure. So there is always the stroke risk. Fortunately, out of 50 cases in our hospital, we have no stroke yet. So, I mean, there is a risk, but the same risk as the impact is different, as you said.
Is there a whole
So,
cases,
do you want me to proceed to left main ostial stenting or not? What's your opinion?
I think it's that, as I said, if the patient condition is stable, and then I fix it, the left main first,
Yeah.
and then do the TAVI
4.0?
procedure.
Okay.
얼른?
Dr. Chair,
Yeah.
please discuss more
Yeah,
points.
okay.
So I'll proceed
And
to.
before the stenting,
procedure.
would you remind the height from the annulus to the left main, because when you deploy the
15.
stent, the stent strut should be protruded for the ostial coverage.
right.
So it makes some obstacle to the subsequent TAVI procedure.
Right. You know.
Yes, fortunately, this patient have a long length of annulus to the left main, just more than 15 millimeter.
Test. 잠깐만. 테스트. 좀 더.
Please discuss about the concomitant PCI and
Inflation. 10.
sequential
Deflate.
PCI.
Deflate.
So could you ask the issue to the panel?
Yeah, perimeter stent, Liberté 5012.
5012.
Test. Yeah.
Why a bare metal stent?
Stop. Due to the size. The vessel size is 6.
Yeah.
Test. Okay. We are deployed at 18 atmosphere, so this is the best we can do. But
Angiographically,
if,
it looks
it's
acceptable.
not enough. We are planned to post-dilate with the 6.60. But angiographically, I think it's good enough. What do you think? Let me check the IVUS again.
Yeah, sure.
Okay. But usually what I found in the literature is that the not severe, just moderate stenosis or ischemia is not a risk factor for TAVI procedure. Surprisingly, even 70% stenosis is not a problem. So there's a lot of debate to treat medically or yes, just a little. Okay.
보여주세요.
So I don't care about any stenosis below
보여주세요.
downstream to the left main. You can see the stand, well opposed. I think this is opposed,
Yeah.
right?
Well opposed.
Yeah, this classified location.
What is
Maybe
the
I
pullback
think stent
speed
is
of the
about 2
IVUS
millimeter
catheter?
protruded. 0.5. Stand a little bit protruded. Yeah,
Yeah.
but still covering the ostium. Okay.
Perfect.
So actually,
sure.
엔조첨으로 좀 돌려봐요. 엔조첨. Actually, we didn't prepare the TAVI yet because there are some issues here. Actually, 제일 처음으로. Yeah, I like to remove whole system. This complex and the distance of the left main to annulus is 15. This is enough space for that.
Okay.
So we are behind the schedule. 그 정도. Because this patient have a tricuspid annuloplasty. We spent some time to get the pacemaker to the LV. Next. So we used the balloon-tipped pacemaker for this purpose. You can see the tricuspid annuloplasty ring and the mitral of the spirit to the tricuspid valve. Next. Another challenging was the calcification of the iliac bifurcation.
괜찮아요.
We couldn't get through the
괜찮을게요.
guiding catheter. So next. So we used the long sheath. Next. So it took times. So now we are starting to prepare the TAVI procedure. If you want, you go to Seoul National University and come back and how to deploy the S3. Yeah, it's kind of challenging, but the lumen is quite enough. Lumen is more than 6.
Yeah.
Yes, I think it's negotiable. Right. Not the sheath, but guiding catheter. There is a lot of room between the wire and the 6-French guiding catheter. That's why. Yeah, we'll check. You can see the stent anyway. So,
픽테일보다
yeah, pigtail wire. Yeah, we have not finished yet. Just so this is out angiogram, the aligning the 3 cusps in one line. This is AP caudal 17, and meanwhile we measure the AL index. The slide on the screen, please. The estimation of artery regurgitation or PVL is quite variable and very difficult. Slide on the screen. Yeah, okay. So very variable. So even the TEE is quite difficult, and the angiogram has a lot of variability. Especially LV-EDP is higher. The AL is underestimated. So we routinely measure the AL index by this method. Currently, we have 0.35.
Yeah.
35, but hopefully we have more than 0.3 after TAVI procedure. So we are inserted the M+ wire and the
박성준 선생님.
Okay, firstly, I like to introduce one of my more team members. So Seungji Park
Yeah, hi.
is echocardiography. Can you show him, sir?
Okay. Yeah.
안 보여줬는데? Okay, she is. And Dr. Lee, Jong-han Lee, anesthesiologist, website is that's working with us for many years. Okay, so 엔저 좀 보여줘. 그전. So it's a 3, the 16 millimeter. We initially go전 view. Yeah, previously prepared like this, and we try to align the stent, the margin, that we have the cranial view epicranial to meet each margin of the stent in one line. The next, and we control the handle, stent in position. This is a very good procedure for the reducing the profile of the stent. Okay, we are going in now.
Did you do
So
the
this is
predilation of this lesion?
No. Normally we don't predilate it.
You did not dilate.
Yeah, I did not. Usually we don't do that. Anyway, for this patient, the annulus to left main is 15 millimeter. It's very long. And another point is that the left coronary concept is large enough.
And you please show us the
why-
hemodynamic of
We're
this
going in.
patient.
Yeah. Hemodynamic quite stable. Blood pressure about 110.
됐어.
Quite stable. So
Please show us.
actually, this patient, the calcification. Yeah, okay,
보여줘.
sure.
저 한번
Please,
보여주실 수 있나요?
the hemodynamic on the screen.
No. 인 카메라. 카메라로.
이거 올라온다며.
카메라를 보여주세요.
Good.
Hemodynamic, okay.
오케이.
Yeah, 103. Sorry, the 17 millimeter mercury, then lower than I told you. Okay, so actually the pigtail positioning is not so great.
테르모 와야죠.
Actually, I tried to push it. No.
Went into there. Yeah.
No, position is not great. Just looking at calcification. Test.
테스트.
Test. Okay. The best position of S3 is a lower margin. Lower margin of the marker is aligned with the annulus. Okay, that's better.
조금 더.
밑으로.
예.
Okay, that's better.
벤트리클. 예.
Okay.
조금 더. 됐습니까?
Okay. Yeah, we start.
Yeah.
The ready? Pacemaker ready? Okay. Pacer on. Blood pressure still high. Pacer off. Blood pressure is as high as 80, so I stopped the pacing. Pacing 180. Actually, pacing 180, that there was the 2-to-1 capture, so I decided 150, but blood pressure too high. Again,
I normally do 150 first and then go quickly to 180.
pacing, pacer on. Oh, no, stop.
Yeah, it's 2 to 1. Go down to 120 or
Pacing
150.
is, yeah, actually, we tried 150 and the capture 1-to-1, but blood pressure is 80.
160.
Now, once you have the
So-
capture, you can increase the rate.
160. Yeah, but the 180 two-tone capture, 150 one-tone capture, but blood pressure high. So I'll try 160. Okay?
약간 올라왔어요.
Yeah. Test. Small test. Test.
테스트해요.
엔지오 테스트.
Angel. Test. A
올라왔어요.
little bit high.
저기 있는
Okay.
그
Okay.
서스템 마커
That's good.
올라왔어요.
Okay. Oh, too low. No. Okay. Test. Moving together. It's moving together. Test.
조금 더.
Test. This is good.
됐어요.
That's
됐습니다.
good.
이게
Okay.
저기입니다.
테스트 again?
이거보다
테스트?
이거보다 조금.
테스트.
저걸 맞추세요. 픽테일
테스트. 왜 안 써? Okay. Lower.
조금
This way.
네, 거기. 네.
It's okay?
네.
Okay. Ready? Pacer on.
피싱.
안돼.
Stop. Still two-tone capture. Yeah, let me try. Let me test. 150.
150 or
150 and the increased rate 180,
180
during,
quickly.
during. Okay.
120 한 다음에
Test. 150. Pacer on.
150.
Pacer on. Yeah, one-tone capture. Increased rate 180. 180. 180. Okay, great idea. Yeah, stop there. Stop. Okay, great. Thank you for your advice. This is great. This is great. Okay. I think this location is okay. Lower margin of the annulus at the pigtail. Okay. Start with 150, increase 180. Okay. Pass around. Yeah, one-tone capture. The increase 180. Still high. Okay. Inflate.
Picture.
Okay.
1, 2,
3, 4, 5, 6. Deflate. Pressure off. Okay. I'll pull back the device. Okay. Yeah. Let me see. But these days, S3 is quite stable. Actually, marker is moving upward, so it doesn't matter. The very stable, and we have a very good location from the beginning. The location of S3 is quite stable as expected.
Sometimes left patient, during left pacing, the valve location usually a little bit a movement into the LV or out. So final defining the location of the valve
I think
during
so. If we have a
pre-dilatation, very important.
If you have pre-dilatation, the stance moves a lot.
But in this case, just pigtail is located in the non-coronary curve, so we can see the pigtail low margin. So it is easy to perform the TAVI deployment singing the pigtail catheter.
So my idea is that if we pre-dilate it,
more stabilized.
There is a room for the movement. So I thought without pre-dilation, the location is more stable.
Yeah, the fact is that
Okay,
there's some
T,
movement
you
of
see the T.
valve.
11 o'clock is central due to the wire.
That's a wire. Yes.
11 o'clock is due to wire. And according to the CT scan, we expected the most frequent location of PVL is between left and non-coronary curve, because there are a lot of calcification there. So we are looking at 1 o'clock. Short axis, please.
Yeah, wait a moment.
Short axis, please. So we are supposed to looking at 1 o'clock. This is central.
So
Most
here is
likely
the
it's
11
okay.
o'clock
But
parametric
I
station.
think T is sometimes not so sensitive to detect the PVL.
Yep.
So let's move to, it is okay. Actually, AL was the mild to moderate before the procedure.
Yes,
so
sure.
I'm pretty sure that the patient can tolerate a small AL, and we'll check the AL index.
So next we will check the AL index.
Before that, the angiogram
Okay.
for the status of the left coronary system, perfusion of the left coronary artery.
Yeah, we can see the flow.
But
in the left
still, hemodynamic is still
Right.
too good.
Yeah, pacing bit.
Yeah, previously he had
Narrow
atrial
QRS
fibrillation.
and the
Atrial fibrillation.
there's some LBBB maybe. There is some block was noted after. 이거 좀 넣어봐봐. Okay. 됐어, 뽑고. Yeah, the QRS was widened after the procedure, but the rate is okay. Basically, this patient have atrial fibrillation, so we don't know exactly about the complete AV block or not, but rate is regular? Non-regular. Rate, if the rate is regular, we can see the 촬영 좀 해요. We can see the complete AV block happened, but the rate is irregular, like atrial fibrillation, so we don't have a complete AV block. This mitral annuloplasty, not the valve replacement for the mitral, just valvuloplasty with the annuloplasty for mitral and the tricuspid. So I don't think we need a dual antiplatelet for 1 to 3 months.
But
atrial
this patient
fibrillation.
is a different
we are-
situation, stroke.
Yeah,
and
atrial fibrillation. Okay,
yeah.
okay.
So
Stroke and
kind
atrial
of situation.
fibrillation
Right,
and
right,
left
right.
main
I forgot.
stenting. So
Yeah. So I start with triple therapy for 3 months, and afterwards I like to go to a clopidogrel plus warfarin.
Yeah.
That's my plan. So there is no pressure gradient and the air index. My technician is measuring the air index. We'll do the final and jaw. 줌 좀 빼고.
그냥 시내만 한번 보여주세요. 레프트 메인 스텐팅하고 같이 보여줄게요. 줌 했어요? 줌하고 더.
So no. Yeah, barely seen. It's quite not kind of difficult to assess
I think
the location left
TAVI
stent.
procedure itself
Okay,
is
angiogram.
excellent.
So in that purpose, the AR is mild, grade 1, and smaller AR than before the procedure. Spider view. Yeah, I like to show the multiple views. T 좀 빼주세요.
네.
Test. Yeah.
AP 크레니얼, LA 크레니얼 하다가 레프트 메인 보게.
에피크레니얼 좀 보죠. 에피크레니얼. 샬로 에피크레니얼.
줌하고.
It's going a little bit upward. Okay. And jaw. Shoot. Yeah,
Looks
there is
okay.
some room between the left main. It's almost covering the left main. Yeah, you're right. But we are not supposed to deliver the implant too high, too low. Actually, increase the risk of complete block and pacemaker.
Good,
Right.
good.
Yeah, you're right.